Good morning or afternoon. My name is Hope Anchi. I'm actually a patient of Dr. Vogel's, and I'm on the younger side of multiple myeloma patients, and so we've heard a lot about the therapies and whether or not the ones that are coming around the bend. But I also wonder, are there studies or looking at things for patients who are now getting this younger and younger in terms of treatments, especially since we'll probably be on this for a longer duration of time?
Well, so I'll start by saying I actually think most of our studies, especially of newer therapies and how we're going to do things better, are actually kind of geared towards our younger patients. And if anything, it's a little bit of a limitation that we don't actually do as many of our studies geared towards our older patients who have sometimes more difficulty getting to the study center or a little bit more frail or have other medical conditions. And one of the more recent advances in myeloma clinical trials is we have actually seen recently some more studies that are specifically geared towards older patients and reducing the intensity of therapy based on what the patients can tolerate. But one of the strengths of our investigations always has been, how can we make things better for the long run? And I think even for some of our older patients, we gear our treatment strategies towards a long time horizon because we want to be able to keep people alive and feeling well for 20, 30 years with their myeloma. And we realize right now that's still a challenge, but that should be our goal. And we're always kind of balancing the effectiveness of a treatment against its toxicity profile, both in the near and long term. And so I think we really are structuring our research endeavors around trying to reach for that long term for all of our patients. And then sometimes we should remember to be a little bit careful with our patients in their 80s and 90s, because what they can tolerate isn't as much as younger patients.
I would just add that we've had so many new drugs developed for multiple myeloma and approved that we are a little bit behind then in the research that needed to figure out exactly how to use each one of them and in what order and in what combination. And that's a good problem to have because there's been so much new development. And as all of you know, as patients, we make decisions every day in your care, and it's hard to have a clinical trial that addresses every one of those decisions about, okay, do we stop a medication? Do we reduce the dose of a medication? So, but I still think it's important to try to answer as many of them as we can with clinical trials, but I think there's a little bit of catching up to do because the initial clinical trials that happen just tell us whether the drug works and is it safe, but then there's many, many questions that come after that speak to some of the issues you're asking about, like over the long term, over patients' long journey with the disease, what's the right order, what's the right balance between pushing too hard and backing off too soon? And those are questions that we kind of just use our clinical judgment and discussion with the patient to make decisions now, but ideally we would have more clinical trials that speak to those questions. I hope we will over time.
Are there any current studies or medications that have to do with detecting amyloid or depleting the amyloid from your body, since it's produced by multiple myeloma?
So there were two studies, right? One was by Prothena with the drug britomimab. I can never say it right. And the other one is Kale. So we know that usually in amyloid, the clone of plasma cells that leads to amyloid production is usually not a big clone. It's a small clone. But then the plasma cell-directed therapies, which we have borrowed historically from myeloma, but modified it for the amyloid patients, so the standard of care, Dara, Cyberg, addresses at shutting down the production of those light chains that cause the amyloid, but we have not had much success in those depleters. And unfortunately, I believe the Prothena study shut down because they did not meet its primary endpoint. And even Kale, the other antibody that was in clinical trial for, that was another antibody, light chain depleter we thought would get rid of the amyloid. From what I remember, I think the study was not positive either. So we still have a long way to go in amyloid.
But what I will add just is that, for most people with myeloma, their myeloma protein and light chains don't deposit as amyloid, which is a complication that affects some people with myeloma and other people who have plasma cells in their bone marrow, but not the other manifestations of myeloma. And so it's a very specific problem that affects some people, but not everyone. But right now, the main treatments that we have, as Dr. Kaur said, are really to go after the plasma cells using the same medications that we use for myeloma. And there are efforts to try to directly target amyloid deposits, but yeah, they haven't been super successful so far.
I'm just like the young lady who spoke earlier. I'm on the younger side. I'm one of Dr. Cohen's patients. I'm not just saying it because I'm bragging about him, but I'm grateful for all the studies that's involved. My main question is, are there any studies out there that relate to family members? Unfortunately, I just had an aunt on my paternal side who was diagnosed too with multiple myeloma and is grateful enough to also be in the same vicinity as myself receiving treatment. But I wanted to know what are the genetic studies are that's out there, specifically for African Americans?
So I can start. So that's a great question and something I really think we need to understand more about. So we know there are families where there are multiple members who have multiple myeloma or similar diseases. So there may be a hereditary component in those families, but the vast majority of patients don't have a direct family member. And we haven't been able to identify yet a specific gene that you can test for that's predisposes you to myeloma, like with breast cancer, for instance, the BRCA1 and 2 genes. So I think this is an area that we really need more study. There is a group up at Dana-Farber, led by Irene Gobriel, that is trying to screen first-degree relatives of patients with myeloma, and they're trying to actually get a large proportion of Black patients because there is a higher incidence of the precursor, the MGUS, before myeloma. And then trying to understand if any of those relatives do develop myeloma, what are the common genetic links? So that would be one study I'm aware of, at least, where there's an effort to try to understand this more. But I think we need a lot more research, unfortunately.
So one of my colleagues at Mount Sinai, Dr. Santiago Tibo, is also looking into genetic predisposition and which genes are. It's in the works, but we're also looking at it. Yes.
I guess independent of the genetic side of it, are there any patterns with how the growth of this disease in the US has compared with other countries around the world? For instance, have we seen more cases in the US over time than in other countries?
No, I think roughly it's been about 30,000. Sorry. You want to?
I was just going to say, you may have stumped us on that one.
Yeah.
I'm not sure I've seen comparative data in different countries in changes over time.
Yeah, I guess I was just trying to understand, like other types of cancer that are hitting the US harder because of other things in our food, our environment. I'm just curious where multiple myeloma falls in with that. Is there a pattern for this particular disease?
Yeah, there is, of course, that disturbing statistic that there are more and more cancer diagnoses in younger people in the U.S. And I think that actually does apply beyond the US as well. But I have not seen that myeloma is particularly implicated in that trend. But I want to say for sure, but I don't think I've seen that.
But myeloma has been implicated with obesity, right? As the rates of obesity have gone up, we've seen that. And there are small case series, which means 300 or 400 patients. I think they were published out of the Mayo Clinic, where they said if you have a precursor, such as smoldering or MGUS, that you're more likely, the rate of progression may be higher. Now, that's only, you need large population-based, thousands of patients to verify those kind of claims, but there's a little bit of work on that.
Hi. Earlier you talked about a lot of the new drugs, and you talked about Blenrep and talked about the eye symptoms. So you were talking about blurred vision. Well, what about people like us that have had cataract surgery and we have implanted lenses? Would that affect that?
So the side effect of belantamab on the eyes is a really unique one that primarily affects the very outer layer of the eye, the cornea, which means it actually doesn't interact much with almost any other eye condition. This is something we've always been concerned about ever since Dr. Cohen started running the belantamab trials at Penn, which is that we were worried that people with other eye conditions would have a tough time with belantamab. And as our ophthalmologists got used to looking at this, they keep telling us over and over that, nope, that won't affect things. And having replacement lenses or having cataracts won't cause you extra problems while you're receiving belantamab. And we've even had patients receiving belantamab get lens replacements for their cataracts while they're receiving belantamab and have it go just fine. What do you think, Adam?
Yeah, I really agree with what Dan is saying. It's a different part of the eye, and unfortunately the cornea, the outer part of the eye, sort of sloughs off and gets remade, almost like your skin cells do, and regenerates. And so even if you have toxicity from the belantamab and get blurred vision, if you wait and just give it time, that corneal epithelium, the layer will be replaced, and then it resolves. So. Correct. I mean, if you have underlying cataracts that cause a little blurriness, and then your cornea gets affected, and you have a little more blurriness, that's how it could affect you, but it's not a permanent change, and one doesn't preclude you from the other.
Got one here. Hi, I want to go back to the just previous topic of where we think comes from, or are there selected categories of people? As a veteran who served in the Gulf War, I am service-connected for that, and I know there are a lot of other veterans who, from that time frame, maybe even 1990 to today, that have multiple myeloma. Have there been any studies regarding veterans and active duty members, actually?
I couldn't quote the studies. I just know from the experience of some patients who are veterans that the VA and the government now recognize multiple myeloma as potentially related to military exposure, like you said, from Vietnam, but also more recently in the I forget the name of the act, but the burn pit legislation. Yeah, exactly. So I have a patient who was able to petition for compensation for that. And then the other is 9/11, actually. So people who were exposed to the 9/11 debris, that's been recognized that myeloma may be increased in that population. And there's also a mechanism for those patients to make claims for compensation through the 9/11 Compensation Fund. And so we've written letters to support those appeals. But in terms of the science of how those exposures cause multiple myeloma, I don't think we really know.
So a quick question. So what is kind of being done to try to have earlier diagnosis, like diagnosis before people have like irreversible damage to their body? So often just late diagnosis. And so, are there any things that are being done, or what can we do as patients even to to try to influence earlier diagnosis?
As people have access to better care, we are getting patients diagnosed at MGUS stage and smoldering myeloma stage, which probably wasn't happening 20 years ago, right? So that's made a difference. We see people earlier, we monitor them earlier. There's actually a study, and I didn't get to read the paper. This came out by just in the past 1 week, that if you have a known history of MGUS or smoldering myeloma, you tend to do better. Don't quote me on it. This came out this week, so I didn't get to read it yet. So I think knowing and predicting when somebody's going to progress to multiple myeloma is helpful from our perspective as well as the patient perspective. But that's where a lot of work is being done in the smoldering myeloma stage, right? Do I agree with all of that? Probably not. But there are efforts to intervene earlier, whether it's at the smoldering stage with daratumumab. I think Dr. Vogel, you presented that study, and actually just today or yesterday, daratumumab is even approved in Europe for early intervention of smoldering myeloma. So I think we as a myeloma community are grappling with that idea. Should we intervene early? And so we don't have irreversible damage, i.e. bone damage or kidney problems, which are the two things I think most of us are worried about. It has effect on quality of life, pain, and all that. And if that is the case, then how should we intervene? Should it be with one drug like daratumumab or lenalidomide, or should it be a more potent strategy, such as doing the 3-drug, 4-drug combinations I talked about, or even doing CAR T-cell therapy? So I think we have good diagnostic tools on picking up people earlier, but how do we go about mitigating those risks is in the work. And I think the study that Dr. Gabriel is doing at Dana-Farber is sort of trying to understand which patients are at risk if there is a high risk of getting it, so i.e. family or Black patients. So we diagnose them earlier, maybe we do screening, and then we then manage them or monitor them. So I don't know if I answered your question, but.
Well, so what I was going to add is that, the concept of finding cancer early and dealing with it early sounds very attractive, but of course involves then finding things to do in a lot more patients, which means you want to make sure that you really know that you're doing something good for people. And the study that I think is probably going to do the most to address that is this amazing study being done in Iceland called the iStop study, where they managed to recruit, I think, half of all adults in the entire country, like 250,000 people, and randomly assign them to get blood testing done looking for myeloma proteins, the M spike in the blood or the urine and the light chains, or not get that testing done to find out, as you follow people over time, if you pick up those diagnoses early, does that lead to better outcomes, or just a lot more worry and extra testing and extra treatments? And we won't have the full results of that study for a long time, but it's already starting to influence our understanding of what do these blood tests look like across large populations of people, and what other diseases are they associated, what are the risks of developing very low-level abnormal myeloma proteins. Now, of course, that study also is very much tied to the population of Iceland. There are lots of groups here in the United States who would not be well represented in that ethnic population, but it will still give us really valuable information. And I think we need more really well-constructed studies like that to tell us in the end what's going to be the right thing to do.
MGUS is common, certainly as people age and as there are more older people, up to 5% of patients above the age of 70, but not the majority of those will not have myeloma. So these questions and challenges of when and who should be treated or intervened on early is a challenging one.
I was just going to follow up with the military. My father was in the Marine Corps in Camp Lejeune, and my mother was pregnant with me, and my mother passed away from myeloma, and now I have it. So it is reflected in toxicities that we are found by. Anyway.
So back to the gentleman who was in the front over here that asked about testing and so on and so forth. I was diagnosed in 2021 and had no idea I was sick. My family doctor found it just through simple blood testing. I would go every 6 months for blood testing because, cholesterol, triglycerides, stuff like that, and I had elevated protein in my blood. So he immediately sent me to get more blood testing. He knew I had something not good going on just based on the protein levels that were in my blood work. So I have been huge advocating with my circle of people and family and friends and Facebook, encouraging people to get their annual blood work because that's how mine was found. I had no idea I was sick. And fortunately, mine was found early enough that I didn't have any lesions in my bones, no kidney involvement. And then the oncologist that I went to in New Jersey works in tandem with Dr. Waxman, so I'm a Penn patient. And I'm just grateful that my family doctor was so proactive in getting me to get the blood work. He ordered exactly the right tests. I knew Friday, he said the protein was elevated. By Monday morning, I was getting a call that I needed to go to a hematologist. Now, he didn't tell me what I had, because he wanted the oncologist to look over everything. But of course, I went down the evil rabbit hole of, Googling it. And at that point, I was terrified and hiding in bathrooms and crying all day long until all the blood work came back and testing bone marrow and stuff. I had 70% myeloma and it was mostly contained in my legs. But we were just really grateful that I have the IgG kappa strain, and I don't have the depletions. So I responded very well to Revlimid, Valcade, dexamethasone, had stem cells removed, and then had the stem cell transplant in July 2022, and I've been in remission since. My immunofixation, thanks. My immunofixation still comes back with just a little bit of myeloma in there, but all of my other blood work comes back normal, which I'm grateful for. And then also something that I did, I lost a ton of weight and went on like a health nut kind of thing to help keep me in remission. So blood work is key, so tell your family and friends, just make sure they get their annual blood work, because I really feel that's what saved me.
That's the benefit of having a really good primary care. I just do want to add that there is a very small subset of myeloma patients where even the blood cannot tell you, and that's called, it's very small, 3 to 4%, but those, where you basically have the tumors and the bone lesions, but not the actual abnormal protein, so non-secretory myeloma. And when you have light chain myeloma, the total protein isn't always elevated. So that if that affects the kidneys, that's the way to pick it up. But it's not always gonna, But that's great that the doctors monitor that and helped you pick it up earlier before damage was ensued.
I'm curious. In the event that we test atomic weapons again, would that have an effect on myeloma rates or cancer in general?
Can you repeat?
I'm sorry. I'm curious that if our government explodes atomic bombs again, if it would affect on myeloma and specifically in cancer in general.
So, there have been a lot of questions regarding the cause of multiple myeloma. And I think it's really important to start off by saying that there's a lot we really don't know. Right? So we have identified some through kind of epidemiologic studies, things that seem to be associated with an increased risk of myeloma. But for the vast majority of our patients, if you say, can we look back and point to some exposure or something, like Camp Lejeune or the World Trade Center or exposure to industrial chemicals or Agent Orange in Vietnam, most people, the answer is no. We can't find anything. So there's a lot that we really don't know. My understanding is radiation exposure is kind of an area of real uncertainty. There's a little bit of data that therapeutic radiation, like for a previous cancer treatment, might increase your risk of myeloma. But one of my colleagues who had been at Penn, Brendan Weiss, who came to us from the military and was very interested in the etiology of cancer, I'd like to point out that after the Chernobyl nuclear accident, myeloma was not one of the cancers that seemed to pop up more frequently, whereas other cancers did. And so leaving aside the political questions of whether we should be doing more nuclear testing now in the United States, there certainly might be...
They don't know if it works or not.
There certainly might be bad effects health-wise from exposure to radiation, depending on how much radiation gets out. But we're not sure that myeloma would be one of those.
I see. Thank you.
Yeah, I'll echo Dan's earlier suggestion to vote. But more seriously, one of the questions I always ask my patients when we first meet, or I try to, is whether you had ever heard of multiple myeloma before you got this diagnosis. And the vast majority of patients have not heard of it before. And so I think when you get this diagnosis, you're like, oh, this is a rare disease. Something must have happened that made me get this rare disease. But remember, though, in blood cancers, we tend to divide blood cancers into like 100 different categories because they're so diverse. But really, remember, cancer, of course, is not uncommon. All of us have a 40% chance of getting cancer in our lifetime. And blood cancers collectively are not uncommon. And so even though it might feel like you got struck by lightning because you got multiple myeloma, really what you got is a blood cancer. And blood cancers are not that uncommon. Of course, cancer is not that uncommon. So we should always, of course, study things that cause these illnesses and try to mitigate risks. But it's also true that cancer is part of the human condition. And just because you got a rare cancer doesn't mean that there was something that happened to you from an exposure or something you did that put you at risk for this.
I have a question, but I just want to say about how you get this stuff. When I started, I worked in the meat department. And I did wrapping meat with the plastic and the wire and all the fumes. Then I became a hairstylist. I did all that with all the chemicals and all. Then I became a fight promoter. And 90% of my men were African American. So I've been hanging with them too much. So this is how I got it. But anyhow, that's the answer to your question. Anyhow, I have I'm in the older part of this part. I know there's a lot of young people here, but I'm the older one. My doctor is Dr. Garfeld. Now, I have a question. We've been through 5 different kind of things. None of them worked, but the one I'm on now works. But just in case this one don't work anymore, am I going to get the antibiotic or am I going to get the stem cell? And he said, Dr. Cohen said, he does people in their 80s. So I don't want you to tell me I'm too old. So if you don't know the answer right now, could you just go home and study my account?
You hear from me all the time. I think you need to hear from one of the other doctors.
So what I will say, in Dr. Garfeld's defense, is that there are a lot of answers that we don't really know, right? And one of the things I said in my talk, but I think you've heard it from other people, is there are a tremendous number of questions that we deal with every day in treating our patients, and the data that we have from really good clinical trials only address a few of those decisions. And we extrapolate data from other, from trials that have been done that weren't designed to answer the question that's right in front of us, or we draw on our experience. But sometimes what we're really going with is a combination of logic and guesswork for an individual patient where we know we have a few really good treatment options, and we just don't know for sure which one is the best. And that means that a lot of times when I approach my patients, I will say something like, I don't know which is the best, but here are the options, and here's what's good about each one, and here's what's not so good about each one, and let's talk together to figure out what makes the most sense to you. Now, there are some situations where we actually have a pretty strong idea of what's the best thing to try, and or where a clinical trial has given us a very clear answer of this is, this treatment makes people on average live longer than that treatment, so you'd better come up with a really good reason to not do that one. And those we tend to say, yeah, this is the right answer for you. But in those areas of uncertainty, sometimes we're stuck, and we could, of course, make it up and tell you this one's the right one, but I think we respect you too much to make up an answer and tell you that we know it for sure. And it's a good problem to have when we have several great treatments and we just have to pick which one to try first. And that's usually what we end up doing.
Yes, I was going to echo that last point, that it's often not an either or, it's which one first and which one next. And because you do have the option to go from one to the next for many of these. And unfortunately, we're still not curing most patients with these treatments. And so the more options we have, the better, because you always can go to the next and the next one. So you'll get there. Right. Sounds like a plan.
No, I'm gonna let you hold it. We've heard. Okay, we've heard more recently in the research world that we're going towards this functional cure in myeloma. That might be 5 years, MRD negative. Like, I just want everyone's opinion about that idea.
Yeah, so I think what you're referring to is there a way we can define cure in multiple myeloma? We've all been reluctant to use that word just because historically myeloma has always come back. But now we have more powerful therapies than we've ever had before, and we have these, anecdotes or subsets of patients on trials who are doing well for 5 years, 10 years, and beyond. So how do we define a functional cure? So this is I think, an ongoing discussion. I do think it has to be at least 5 years. And ideally, I think you should be off therapy, and that's where some of the debate is, because if you're still on maintenance treatment to keep you in remission, does that count really as a cure? When I think of cured disease for other cancers, patients get treated, they finish their treatment, and they're still in remission 10, 20 years later, and they haven't required other therapies. So to me, that would be, I guess, part of what I would want to require would be off treatment. And then MRD negativity is one of the ways that we can assess that, and it has to be probably multiple times in a row, at least a year apart. And I think imaging should be negative as well, so a PET scan. So there's going to be all these criteria that we come up with, and maybe we will get there. I think there's hope now that we're going to get there.
I'd like to add that I think it's important as patients to keep in mind that some of the terms that we throw around weren't designed really to be applied to the individual patient. I actually think functional cure is one of those. I think that's really an endpoint for clinical trials. And what we as researchers and then often drug companies are interested in is, can we find an endpoint for our clinical trial that we all agree is a really good thing to get to, but doesn't require waiting 15 to 20 years to see how long people are going to live, so that we can move things forward and decide between two treatments which one is better. And so you then have to come up with a definition and do testing and figure out, does this person meet that definition or not? Part of the problem with calling something a functional cure is when you introduce the word cure, it's something every patient wants, and it's something we want for our patients, but to me, a cure means the cancer never comes back. And you can't define that for sure with any test at 5 years, or maybe we can, but it's going to take a test that, a trial that lasts 20 years to find a definition that we know reliably predicts that, which means that no matter what definition we come up with, it isn't necessarily going to help any of you guys or us as your doctors here today, which is one of the tricky parts about some of the testing we do, like the minimal residual disease testing on bone marrow samples, which gives us some information based on a technology that we have here right today, but doesn't reliably predict what's going to happen to an individual patient over the coming years. We know stuff about groups of patients who have test characteristics, but not so much about the individual, which means that when we're throwing around terms like functional cure, I think we want our patients to recognize that what really matters to you is living a long, happy, productive, good quality life. And our treatment should really be geared towards that. And all of the other definitions that we come in along the way of a complete response or a durable complete response or a minimal residual disease negative response should be in service of that goal. And that's really hard to measure, so we come up with these other things so we as researchers have an easier time measuring it, but that doesn't necessarily tell us what to do for you specifically today and what testing you should have done, which really should be geared towards making sure you're doing well for a long time.
Yeah, I'm fully in favor of coming up with uniform definitions for things and using those rigorously, because I think words have to have meanings, of course. But I also think I just want to echo Dan's point that a lot of things that we use to describe groups of patients on average in publications of clinical trials are probably different than the way we should talk to individual patients. And we know that myeloma is a disease that can be dormant and undetectable for much longer than 5 years and still relapse. And we also know that there are patients who have been treated, with traditional myeloma therapies, not the fancy immunotherapies we have now, who 25 years ago or something, got a stem cell transplant and remain disease-free. I also sometimes think in the myeloma world, we kind of, we talk about these questions as though we're encountering them for the first time, but actually in other diseases, they've been dealing with the same question for a long time. So think about breast cancer. You have patient who gets breast cancer, has surgery, gets chemotherapy. In many instances, she is cured, but there's still always this risk that it can come back even 5, 10 years later. This isn't actually a unique problem that we face in multiple myeloma. It's present in a lot of different cancers. And always what we're dealing with are probabilities. Even when we define a cure, what we're saying is it's likely maybe that somebody's cured, but there's always going to be exceptions to the rules, and we're talking about probabilities, not certainty in any individual case.
I think it's hard to follow everything that's been said, but I'm going to echo a lot of what everyone else here has said. I try not to use that word because it sometimes can give a false hope. And that's where we're not. We don't know, like as Dr. Garfel said, what the probability is that even if you get CAR-T or whatever, you're 5 years out, is there a small chance it's going to come back later, right? So I think the word carries a lot of weight. So it's about, but one thing you said that kind of struck to me is like, this is not a unique problem to myeloma, and other diseases have been dealing with it, but we are actually starting to talk about it. And I don't think we talked about the word cure or anything related to that, whether in our trials or our research ever before. So that's a good problem to have. I guess that's one step in that direction.
Yeah, hard to follow up as well. I echo a lot, and I think it's right. Even though these are terms across many different cancers, we often, for every therapy and step along the way of our patients, want to be honest about what the average expectation for is, but also paint a picture of what the range is. And so, for example, a lot in our discussion, both about the autologous stem cell transplant and about CAR-T, it's a huge range. And so even though our discussion is surrounded around what the average experience is with those for our patients, so for the transplant, it means in average almost a doubling of the remission time, and that means a time where you are well on minimal therapy, having more space and time to kind of course live out the other many things in your life, and certainly more finding out a group of people who have done quite well for a long time with CAR T-cell therapy, but the range is very big, and so for some of our patients, even though it's would be disingenuous to set up the expectation that the autologous stem cell transplant is cure. A few patients have done well with it for much longer than we expect, and same for CAR T. And so I think it's just a lot of it is which is the kind of right language to set up in terms of expectation, even though we're certainly thrilled when long-term follow-up for our patients is really, really good. But certainly the main message is for some of our patients who might, do very well, feel so well that they're lost to follow-up. I think that's the most important thing, is that we do not want them to just come back very sick without having been able to see that coming.
Okay, thank you. I heard a lot about that at IMS. It seemed like, I'm like, kind of what? So anyway, thank you for your input on it. One more question. This will be our last question, then we'll wrap up.
Again, thank you all for coming, for your time, and for your great presentation. I want to call a big round of applause for all of them. I'm so grateful to you all. Here's a question that bugged me. We heard of the high-risk patient a lot. High risk. Can you clarify for us, at least for me, how you define the high risk? And the next question is, do you see more MRD positive, relapse, refractory patients from a high-risk patient?
So, as we're evolving our testing strategies and the tools that we have to diagnose and that are evolving, the definition of high risk has been evolving. Most recently, the IMWG and IMF definition has come out. But I'll say one thing. I think we understand very little about the biology of multiple myeloma. As researchers, as clinicians, and I've had high-risk patients who've done very well for a long period of time with sort of similar treatment strategy that I would have given a standard risk patient. And I've had standard risk patients who have no TP53 mutation, no translocation 414 or 1416, relapse within a year and a half of diagnosis, or even primary refractory. So I think that's what I will leave you at, that I see relapses in both group of patients, standard risk as well as high risk, earlier than where I expected them to relapse. So we need to do more in terms of understanding disease biology.
And I was going to just add, because I agree with everything, is that when we use the word risk, there are really kind of two purposes for assessing the risk of multiple myeloma. So one is for the individual patient sitting in front of us, trying to decide what kind of treatment to get. And that's actually a really tough discussion because, again, all you really get is kind of probabilities. And I'm not sure that any of our testing, and there are multiple definitions of what high risk means that have evolved over time, and even now, things that don't always fit into a definition, but that affect our thinking as doctors looking at the patient in front of us. And yet, patients' individual experience can vary widely. So all we can really tell you is a little bit about higher probability or lower probability of having worse treatment outcomes. But the real reason that we came up with the definitions of high risk was, again, to help guide our clinical trials so that we could identify groups of patients who, on average, were going to do worse or better than other groups, so that we could understand when we're looking at a group of patients on this clinical trial and then comparing them over to a different group of patients on another clinical trial, how did those groups compare in terms of their risk or how bad their myeloma was likely to be? And then how should we think about the results of each of those trials in the context of what that risk looked like? But those definitions can be very useful from a research context, but not necessarily useful to the individual patient saying, what should I do now? And in fact, there's a lot that we haven't yet figured out about how the level of myeloma risk really should change our approach to doing treatment. There are only a few clinical trials that have suggested that one particular approach would be better for a very high-risk patient. And so mainly the results of all of that risk testing affects a little bit how we talk to our patients in terms of, again, balancing that aggressiveness of treatment versus the side effects, where the more high-risk features, the more likely we are to lean a little bit more towards the more aggressive treatments and weigh the side effect profile a little bit lower because we're more worried about the myeloma in general. But there's not a whole lot of concrete data telling us specific things that we really should be doing differently.
Yeah, I would just add that I completely agree with all that's been said before on this topic. I also want to, I think we should be cautious too about for patients who are standard risk or maybe who are MRD negative, which everything tells us is a good prognosis, that we don't hold back safe, effective therapies from them because we think, they don't need them. Maybe those patients who are standard risk, who are MRD negative, are the ones who are going to be cured if you push ahead with the same therapies in them. So I think we got to be really careful. We all, I think, make marginal changes to treatment plans based on risk status, but I think we should still make sure that every patient has every therapy available to them unless we really get hard, good data that tell us this group of patients just doesn't need X, Y, or Z therapy.